This is the Healthcare Education Transformation Podcast, a podcast brought to you by two physical therapists devoted to helping physical therapists and other healthcare providers become better educators to patients, students, the community, and each other by interviewing prominent and passionate people within the realms of healthcare and education. The Healthcare Education Transformation Podcast is intended literally for educational and entertainment purposes only. No clinical decision-making should be based on only one source, and therefore this podcast should not be used as personal medical advice. While care has been taken to ensure accuracy, occasionally mistakes and factual errors can be present, as we are only human. This is our journey on the road to becoming better educators, so get ready with your pen and paper as class is about to begin. Hey everybody, and welcome to the podcast today, and you are listening to the Healthcare Education Transformation Podcast. I'm one of your hosts, and my name is Brandon Powen, and of course, as always, I am joined by my other half, F. Scott Fiel. And today we have a very, very special guest that we are so happy to bring you guys today for a good discussion on mentorship for the clinician and students. Tonight we welcome Dr. Tim Flynn. Now, for those who don't know who he is, Dr. Flynn is a board certified in orthopedic physical therapy, a fellow of the American Academy of Orthopaedic Manual Physical Therapists, and a frequent presenter at state, national, and international meetings. He has widely published 5 textbooks, 6 book chapters, over 75 peer-reviewed manuscripts on orthopedics, biomechanics, and manual therapy issues. His awards include the James A. Gould Excellence in Teaching Orthopaedic PT, Richard E. Erhard Orthopedic Clinical Practice Award, the Stephen J. Rose Excellence in Research, which he got twice, the AAOMPT Outstanding Research Award, which he also got twice, and the Distinguished Alumni from the Marquette University Program in Physical Therapy. He is a past president of the American Academy of Orthopaedic Manual Physical Therapists and associate editor for the Journal of Orthopaedic and Sports Physical Therapy, or for those more commonly know it as JOSPT. Dr. Flynn is a principal in Evidence in Motion, or EIM, which is an educational company dedicated to elevating the physical therapy profession. He is now the owner and maintains an active clinical practice focusing on chronic pain disorders at Colorado in Motion. Dr. Flynn is a professor in the EIM School of Physical Therapy at South College, where he teaches in the area of musculoskeletal management, chronic pain, advanced manipulation skills, and evidence-based practice. His primary clientele is made up of individuals who are experiencing low back pain, chronic spinal disorders, failed back surgeries, and chronic pain disorders, and his clinical expertise is frequently sought by national and international clients. He co-hosts the Pain Reframe podcast with Dr. Jeff Moore, and for those clinicians, or anyone for that matter, who treats persistent pain or is experiencing persistent pain themselves, I really highly recommend that you guys look into this podcast because they've really got some fantastic information from clinicians and patients, about a wide variety of things regarding pain, and I highly recommend that you guys check it out, and we'll post a link in the show notes as well. Now, Tim, thank you so much for all your dedication and contributions to the profession of PT and for all of your efforts towards addressing the opioid and persistent pain epidemics that we are facing. And I realize I know that you've done a lot more in your career, as I kept your bio pretty brief, but was there anything that you'd like our listeners to know about you that I didn't mention in this intro here?
Well, first of all, guys, thanks for having me on the show, and you did an excellent job. Thanks for giving me those plugs. And I'm joining you guys on what will soon be a early winter evening.
Awesome, Tim. So glad to have you. Before we get into, how to be an effective mentor, the first question in this endeavor for the clinician, and particularly for newer clinicians, is when to transition to that mentor role. What are some essential characteristics that a clinician needs to possess to be ready to step into the role of a mentor to newer professionals?
Well, that's a big question, and I think I would step back and really say that mentorship, in my opinion, really, and when to become a mentor is, there's not a particular route, because it really depends on what is needed. And I would argue that I've been mentored by many of my most, early students, that have taught me areas where I need to grow, and that it really is a two-way street between the mentor and mentee. But again, a mentorship might be, colleague to colleague on the level of, something like mindfulness, where, one of your student maybe, or an intern may be very involved in some other personal health issues and or personal health promotion, and may advise the mentor on ways that they can move along that line. So I guess I'd start by saying there's never really a time too early to be a mentor, and in fact we all are mentors in one way or another. So I would suggest that it's we be of some use when it's necessary, and that to me is the first rule of good mentorship is trying to make a difference and better those around us.
Yeah, no, that's a good point, and especially for me as well, being 2 years out of school and trying to get my clinical pattern recognition and set mindset going. And I guess that's always the tough part, is knowing when to actually step into that role to be a mentor to newer professionals coming through. I feel like that's always a tough thing, but I think you had a pretty good answer there, Tim, and that definitely clarified a few things. And of course, there's a bit of a parallel in patient care with first going through an initial evaluation. A mentor or an educator should evaluate where that mentee is at and assess certain things. And do you think you could walk us through how you initially evaluate a newer clinician or student that started working in your clinic?
Well, sure. And first of all, I'm only in clinical practice 1 day a week, so I'm probably not the best person in our practice to really do that. Dr. Terry Gebhardt, a colleague and business partner, really takes the initial intern, and we have a pretty regimented way of how we bring on new folks or interns. And it really starts by, I would say, expectations. And those expectations are set well before they get to our clinic. And so that the clear understanding of what we expect you to know coming into the clinic, so that there's no frustration on either part in terms of, we're here to shape, to build, to help you grow, but it's a two-way street, right? You need to come with a certain toolkit or tool set that allows you to blossom. So it really starts with that. Maybe an example might be helpful, this idea that we start with, at a minimum, we're primarily an outpatient clinic. We do some home-based pediatric care. We're 0 to 100 in terms of the types of populations or age of populations we see. But if we say focus perhaps on the musculoskeletal persistent pain area of our practice, Terry would expect when you walk in day one, you should be able to do an upper quarter, lower quarter screen in your sleep. You should be able to, know your nerve root levels, know your myotomes, dermatomes, etc. You should have a good foundational understanding of applied anatomy and kinesiology. And the first thing you'll do is, run through an examination on him and demonstrate that. And it's often there's a disconnect when those expectations are set and someone does not enter with those skills. And you can imagine a mentor, if you give a playbook, you expect folks to follow through with that. I mean, that's an exception, but I do believe that sometimes we're not clear enough on our expectations of new people coming in, what is expected of them on their initial day, and be ready to produce that.
Sure. No, that makes a lot of sense. And, I don't know if I mentioned this before, Tim, but Scott and I recently got certified to be CIs for the APTA's credentialing course. And, kind of what they talked about with that is really how to really examine to see how your student learns, how your student processes things, and what's ultimately your student's optimal way of learning. And I think they recommended, I think it was a week to kind of figure it out. Scott, you'll have to back me up on that. I think it was a week to use it.
Yep, that sounds about right. I think it was 7 to 10 days or so.
Did any of these people giving the course own a clinical practice, a private practice? And
no, I think one of them was a CCCE in the hospital, and the other one was an ACCE for a DPT program. I don't know if was it different for yours, Scott?
No, both of mine were, one was a CCCE of a DPT program, and the other one was a professor for the same PT program.
And I'm not trying to be hypercritical here, but I think there's a disconnect with the ivory tower, which I sit in. I'm a faculty member at South College in Knoxville, Tennessee. But I think there's sometimes a disconnect of what is required of a clinic that is high-functioning clinic and the expectations of what that because of those requirements, what is happening there. And what I mean by that is, it is a risk to take on any intern, at least in high functioning clinics, whether that be hospital based or private practice based. I mean, it doesn't matter. But if you're in a high functioning area where there's very little room for error and expectations, spending a week or 10 days just kind of figuring out, how one learns is probably not, in my opinion, the best use of time. Now, don't get me wrong. It doesn't mean to be hypercritical. It's just that those expectations should have been known before the person actually steps into the clinic. What type of warning they're at. They should also be matched in a way that they know, well, this is the type of feedback that you will get. And feedback is feedback. It's not personal. It's designed to provide you a window into where you're at. And so I think sometimes we've lost some of the good stuff of, the old school. I grew up in the military, and it was just pretty direct about, the expectations of what you had to do. And if you didn't meet them, well, you went home and you made sure that next morning that had changed dramatically, or you weren't allowed to stick around. I think we're very often, we're not helping our students grow as excellent clinicians when we give them a pass if they're not fully prepared as they enter the clinic.
Yeah, that's definitely kind of part of growing up in the participation ribbon era, where I think if you're not making critical mistakes and learning from them, and everybody's just kind of getting passed along, you're really not helping anybody, let alone the profession.
Yeah, and I would say that's one of the biggest things that for those of you that know me, I'm a huge student advocate, and I'm extremely positive and professional with our students. I'm sure I make mistakes, we all do, but when it's feedback, I really try to teach students that, it's not personal. This is about growth. This is about, my job is to point out where you can do better. And I fail a lot when I say things like good job. In fact, one of my faculty members just sent me that clip from Whiplash. I don't know if you guys saw that movie about the jazz conductor college. I don't know if it makes sense. He mentors a drummer. I have actually not seen the movie. I've only seen the clip, but if you guys just Google Whiplash and good job, it's a little raw, but basically he says how meaningless that term is, and you can't act on that type of feedback, right? There's nothing than a ribbon with that, right? You get a ribbon, but I don't know, can I improve, or that's the top of the game, right? That's just such a cheating way as a mentor. And I'm speaking from experience because I've done that way too much.
Well, I think recently, Tim, Carol Dweck's book, Mindset, and Angela Duckworth's Grit, both kind of talk about how we as parents probably need to do a better job of coaching and giving feedback, positive feedback at least, for their effort in, how they got to the point that they did or the outcome that they did, as opposed to, like you said, good job, where they can't really improve on it. They're given a pat on the back and that's it. Like, well, okay, well, now what? What's the next step? So I think you make a great point with that.
And I think what's interesting is, as physical therapists, it's part of who we are because we believe in people, right? I mean, we believe in the power of rehabilitation, and it exudes across all our encounters, whether it be in a mentor role or with a patient. And that is a wonderful attribute. But sometimes we then do not fully shape our feedback to make it actionable. And the hardest thing as a parent, I don't know if you guys are parents yet, but the hardest thing is watching your kid struggle and knowing that it's the right thing to do, knowing that especially you get to a point you have means that you could probably help them out, but that's the absolute worst thing you could do for them. And that to me, it's harder to withhold support than it is to give support, especially as physical therapists. So it is a fascinating topic. I think about this stuff a lot. Again, it goes back to what you guys said: grit, resiliency, pushing through when it really sucks, and embracing the suck because it's not about us. And that's where I always go back. Being excellent in our field is not about us. We are called to help and serve others. So if our life sucks a bit at the time, it's good because it will make us better in our service to others.
Absolutely. Definitely the struggle. Without struggle, there is no strength. Definitely seems to hold true for that one. That's very true, Tim. And Tim, to kind of back up a little bit with how we were talking about, seeing how that individual kind of gets accommodated and stuff to the clinic. And of course, with certain clinics being there, very low room for error with that. I'm curious to kind of hear what your thoughts are on, regarding the best practices for physical therapists, clinical education task force, and kind of their recommendations on the whole changing the clinical education model. And, of course, we recently had Kathy Myrella on, and she kind of talked about, some of the issues that they're having in terms of, how it's financially straining on clinical sites and how it can have these kind of lasting consequences that you had mentioned before. What do you think kind of with that? What do you think are some ways that you feel like we could better address that problem overall?
Well, first of all, I believe in depth, not breadth. And what I mean by that, I'd much rather take a student in outpatient musculoskeletal that spent 6 months at the best neuro rehab center doing an internship, 6-month internship at a neuro rehab center, and that was highly rated, highly skilled, and is a kick butt learning environment. I'll hire that person before someone that, rotated through 3 different outpatient clinics in musculoskeletal practice. Because I know that the intense neuro internship, even though they maybe got exposed to nobody with spine pain, they were taught how to think, how to problem solve, and how to work through complex problems. I'll take that any day. I can teach people to manipulate. I've been doing that for 35 years. That's pretty easy to do. Teach them to go through, a systematic examination of the musculoskeletal system. We can teach that, but it's much, much harder to teach clinical reasoning, in-depth thinking, and a grit to push through really challenging populations. So in summary, I basically think the way we fix a portion of fixing the clinical education problem is having longer internships with high quality facilities. I'm clearly biased. That's a model that I've been working with and advocating for the last 15 years of my career, that it needs to be depth, not breadth. And if in an ideal world, we would rotate for, 3 months through the highest skilled pediatric, geriatric, musculoskeletal, neurological, spinal cord, amputee prosthetics, skilled nursing facilities, home health, on and on and on. That is not realistic. And therefore, students are always only going to get a sampling of environments. The key lies in the power of great clinical instructors to teach people how to be excellent thinkers that have high emotional intelligence and can manage in a complex healthcare system. And so I will take depth any day over breadth of an experience.
Yeah, that's a great point, Tim. And that kind of brings me to my next question. What are your thoughts on using the Socratic method with encouraging self-reflection with the mentees and kind of critical thinking skills?
Well, I come from an undergrad Jesuit background, so I obviously like that type of model of learning. And I like it just as a teacher, just you quickly understand by the question someone asks where they're at. You can see, oh, okay, this is where you're at. I gotcha. And this is where well, what about this then? And you can then reframe to where they're at and kind of get them, moving up the next level. So I love that methodology. Now, how does that work in a clinical site where you're moving through very rapidly through the day, and literally each patient encounter you could spend 2 hours discussing that encounter. So the challenge lies to me in picking 1, 2, or 3 key things that day that were really game changers, and see if the intern, student, resident, fellow really picked up on that. Did they pick up on, Sally, did you see that micro expression when I asked her this? Did you pick up on that? That was the biggest learning I had about her all day. And yet no words were said. It was how she moved when I asked that question. And, pointing out those little things that, are really effective in making you a skilled clinician. And that's where I think having the background of a solid foundational understanding of examining patients allows you to quickly get into more the essence of expertise, if you will.
Absolutely. That's a good point, Tim. And, of course, kind of with patient care, we kind of really make sure we have objective data to kind of back up progress. But I'm going to kind of transition that and kind of relate that to either the mentee, whether that be the clinician that's undergoing mentorship or the student. How would you recommend measuring that individual's progress towards their long-term goals in the clinic?
Well, to me, if we're talking on the internship level, obviously looking at really the soft skills is where we believe the biggest gain can be made. Obviously, some students come in with exceptional emotional intelligence, high-level soft skills, but those are really the game changers in terms of measuring. It's really just holding accountable. Like, okay, these are agreed upon goals. What have you actually done and actively done to meet those? And like any goals, whether it's in mentorship or anywhere else, you got to write them down, and you got to revisit and follow up with them. And so I think that's really that's really the bottom line. You got to write it down and you got to follow up, because we all are guilty of that. And I'm the worst. If it's not written down, that goal gets pushed down or forgotten, more likely.
Yeah, I think I'm guilty of that too. I like my goals written down. I even, if it's goals for the day, little lists and stuff like that, I write them all out so that I can check them off, because if not, there's a good chance my scatterbrain's going to forget about them.
And that's a good strategy. Just telling students, every morning I want to see your top 3 goals for today. And asking that. And the act of writing it down, it goes back to that. It's really like the 5-minute journal. I don't know if you guys use that, where it's really a positive psychology journal where you write down, you wake up with, what 3 things are you thankful for? What would make 3 things would make today great, and 1, stretch kind of thing for the day. And actually, I use that with students and say that's a perfect transition to use in the clinic. On the days I'm in the clinic, I look at my what would make today great. All of my 3 things are always related to patients I'm going to be seeing. I'm already focused and primed to be engaged with certain ones I know that I've struggled and been challenged with. So it frames and hyper focuses me for that encounter. So even though it's kind of used in improving mood, it's a simple strategy that's great to be used for mentorship and for all of us every morning. Just writing down 3 things that you're thankful for, and 3 things that would make today great. And then at the end of the day, you should look back on them and what could you have done better today?
Yeah, so Tim, you just touched upon this briefly, but I'd like to go into it in a little more detail. Like with being a clinician, as with many other aspects of life, self-reflection is so critical to further self-development and learning, especially when you're trying to progress toward expertise, right? That's feedback. Self-reflection is one of the main things that kind of separates experts from novices, So from the perspective of a mentor, can you maybe describe your self-reflection process and what that is throughout the course of mentorship? Like, what are you using to assess effectiveness?
I continually changed, and I think really the way I'm self-reflecting now is being much more intentional about daily meditative practice to really turn off my mind, try to reset it and clear it. What we know for a fact now is students and mentors are overcome with too much information and noise and just frickin' clutter in the system. system. So in order to be effective, we have to have some type of practice that is mental clearing, that allows us to really focus again, since we're so distracted. We are a distracted society, severely distracted. So personally, that's what I've committed to and try to do, and do some journaling each morning to try to make myself a better mentor. And that's what I encourage in my students and interns, residents, fellows, to do the same thing, to do those practices that open the mind to allow you to be more successful. So it is, mindfulness is, another way to use. And we must be mindful, and therefore the feedback is heard, taken in, and can be acted on. So to me, it's almost like we're stepping back. We're going back to really, the Jedi Master, if you will, that really is this very much, Zen mindset. And again, I don't want to get far out there, but that's what the science is telling us. The cognitive neuroscience is telling us we got to spend time, training our brain to be a open and effective channel or effective system to grow. So that's probably the biggest thing I would say helps both myself and then to the mentee.
I love it, Tim. I love it. And I couldn't help but notice that little Star Wars plug you threw in there. Are you a fan by chance at all?
Yes. I mean, mainly through the boys. Our boys are now 30 and 27. But I mean, we, had they were actually called VHSs. These were like plastic things that had a tape that went through them. So we had all of the Star Wars, the original Star Wars series there. And they were frequently being watched in the house.
Oh, that's awesome. Me too. I mean, when I grew up with it, that's how I grew up with it too, was VHS, and then it switched to DVD pretty early. So that's awesome. That's funny to hear. And and Tim, kind of switching more, that's a great take on self-reflection. But now I'm going to switch gears and kind of ask, kind of what you've learned. And what are some of the hardest lessons that you've learned about being an effective mentor that you've picked up throughout your journey? Oh,
that's a tough question. Just like, that failure, understanding failure, and don't beat yourself up too much, because we all do it. And that's, I think, a sign of once we get past that. So mentors and mentees, we're both doing it, which is crazy. So probably, I think the thing I've learned is try to be more clear with expectations and holding people to those expectations, because it's not my natural tendency. I'm a nice, friendly extrovert and just have high expectations, just assume that's the way it is. And the person may have high expectations of themselves as well, but it hasn't been clearly articulated what that looks like, so that I haven't clearly articulated this is what, success looks like, and agreed upon that that's what success is. So that's probably the biggest thing I've learned. Just try to be better at providing feedback that is not just good job.
Yeah, Tim, what advice would you give to the clinical instructor or mentor to provide the best possible learning opportunity for students?
Well, I think it really is if you exude, great clinicians just exude this positivity to the patient. And even though you're there in a mentor role, the mentee secondary. The patient sits at the center, and so, wherever you're at, it's not about us, not about the mentor or the mentee, it's about the patient. So that hyper focus on them, I think that's the skill set that I learned from my best mentors. I had Dr. Phil Greenman, a DO from Michigan State, no longer living, but really a huge mentor of mine. When I first went into the clinic, I was at Michigan State in the osteopathic school, and was, the first PT teaching in their CE that was on manipulation, because the folks first they didn't allow PTs for a long time, and then it was mainly MDs and DOs, and he was just one of those mentors that threw me in, as the first PT in front of these groups, even though I was with him for, 2 weeks in his clinic, said, "Oh, we got a course coming up. You need to help lab instruct for this." But I digress. What I learned from him immediately was I was expecting to learn all these exceptional techniques and all these secret techniques that we weren't learning in the clinical education courses. Instead, I saw a highly skilled examination and incredible patient interaction where I just said, "I want this guy to be my doc." This is the doc. I don't want to go to anybody else. I just want him to be my doc. And now we know what that is high emotional intelligence, high therapeutic alliance. In 1989, we didn't have those terms. But that's what I was witnessing, high emotional intelligence and exceptional therapeutic alliance where he resonated with the patient. And I was like stunned by that, how that worked. And that really, set it off with, that was an observation and just, I want to, be like that. And, and there wasn't a lot of him telling me what to do. In fact, he gave me very little feedback, but he modeled effective interactions, behavior, and professionalism. So it was really a modeling that I tried to emulate. In summary, I would say then model excellent patient care and excellent interactions with patients, and check your student for knowledge of that. What was powerful about that encounter? What was not as powerful? When did the patient really seem to get resilient and puff up their chest and feel strong? When did they kind of feel like, they were hurt or they were weak? What was it in the encounter that you provided a positive framework versus a negative framework? I think it's totally undervalued. Yet we're seeing that the research, it's less what you do, it's more how you do it. And I think we've been looking at a lot of the research wrong because we were taking little pieces of wiggling this tissue or scraping this tissue or sticking a needle here versus it's the whole encounter that is part of that intervention. And yet it's harder to measure those different elements. But now some cool studies are showing that, giving positive messages versus neutral messages changes the outcome in a patient. And I think, again, people have heard me say, I'm discounting manual skills. I'm a manual therapist. I manipulate every time I'm in the clinic. I do trigger point dry needling. I'm very hands-on. And what I often say is, when I place my hands on the patient, they should be feeling the hands of an expert. That's because I've done it thousands and thousands of times. And there is a difference. And that all that training, maybe the reason I trained may be totally wrong, but it did not harm me. It made me a better clinician because my hand skills are more gentle, therapeutic, comforting. And that happens through rigorous practice over and over. Even if we realize we're not, moving this 2 degrees to the right and, 3 degrees rotation and, this and that.
No, absolutely. And Tim, for the next question here, you kind of touched on it a little bit before. So of course, with the productivity demands and reimbursement pressures facing PT practices, it can be hard to implement time for structured mentorship at times. And often, when financial pressures hit, mentorship and education are sometimes very commonly initially pushed aside. And, what are some of the other tricks, besides what you've mentioned earlier in the episode, that you found to still effectively mentor others in the clinic, despite these challenges of managing and working in a physical therapy practice?
I think it's actually not that hard if the internships are longer, if there's some productivity by the intern on the other end where they get trained up and they then begin to get given more and more freedom to practice. And then, so even though productivity may go down initially with the training, then it goes up in the end. And all it has to do is at least balance out. And I think with longer clinical internships, that happens. It's the short ones where you're just getting where the person's productive and then they leave. And just the burden. I mean, it'd be fine if the schools were paying the clinical instructors part of the tuition for teaching, but that's not what's currently happening in physical therapy. In other programs, it's more tied, medical schools, et cetera. There's productivity and financial gains from those folks. And we could spend hours on that topic. But in essence, I think it can be very well done. It's really a model issue. If the model's correct, it can be done in busy environments and education shouldn't be pushed aside because, again, we're doing it all the way, I still get mentored and everybody, you're in an educational clinic where mentorship happens no matter how far you are along in your career.
That's a great point, Tim. And I think, that's what makes expert clinicians. The fact that they're constantly willing to learn and that the door's always open. It's about just taking everything you can from every person you interact with and just learning every little bit along the way and just being open to it. I think that really goes a long way when it comes to expertise and expert clinicians.
And I think you hit it on the head, because we can learn from each other, and you learn from a question asked. You're like, I've never really looked at it this way. My way of thinking has kind of been going down this pathway, and it gives you that pause where you say, oh, I'm doing this out of habit. Habit might be effective, but my rationale was truly habit. It wasn't this well thought out, reasoning. It was like, no, I've always done it this way. Okay, and those are times that should be questioned. Doesn't mean that it might not be good, but it should be questioned.
Right, absolutely. And I think that's one of the reasons that we kind of started this podcast, was to kind of look not only at physical therapy, but across all healthcare practitioners and all healthcare education programs, and see what we could learn from each one, and kind of help start breaking down the silos so that we can kind of use that interdisciplinary approach to really help benefit the patient in the end. But Tim, thank you so much for taking the time to talk with us today and for providing some great insight to our listeners. We like to end every episode with this question to each of our guests. If you could change one aspect of healthcare education, DPT or other healthcare provider related, what aspect would you change, and how would you change it?
That's an easy question for me. My pet peeve is laboratory instruction. I'm a laboratory instructor. I'm an educator who feels passionate about, in the fields where examination occurs, particularly physical therapy, where we are doing physical things, we're motion experts, we use our hands. Those laboratories are sacred time. And if they're not run with military efficiency, with tens, dozens, even hundreds of repetitions of physical examination skills, treatment skills, that we are doing a disservice to a whole generation of professionals. For example, I expect if someone is doing a neurological screen or a neuromotor screen of the lower quarter, they should have done that at least 50 to 60 times before they ever enter a clinic. That's the first step of any, hip, back, knee, foot, ankle exam. So, you should have at least done it 10 or 12 times in each of those regions, right? So I'm a stickler, and I think that we don't have enough highly skilled clinicians as laboratory instructors that are really drilling and practicing those skills. Because if you have that as rote memory, I like to say it's a dance. It's this dance that you do. Patients immediately say, oh, I feel like I got examined really well. And we know that the payoff may not be that high. We're picking up a few of these outliers, but you can confidently say, the good news is, your neurological system is functioning well, and you are in the right place. People that cannot conduct a thorough physical examination never actually know what's going on, because they never really got a baseline. They never really know where that patient starts. So that's the one thing I would say I would change. We do it at South College. We're sticklers on it. It is probably, I think, my best value anymore as an educator is teaching junior faculty how to run exceptional labs that are well organized with high volume repetitions on multiple partners, while they're fun, music is playing, and people are in an environment of growth and learning.
Yeah, I think that's a fantastic take there, Tim. And I think that'd be a great way to kind of really, bang out the reps kind of before you get it, because that's what makes it comfortable. Like for me, like when I first came out of school, like I struggled with manipulation because I just feel like I couldn't get it right. I wasn't getting to the appropriate barrier and getting the speed. And, with taking Jeff Moore's class and like going after it, practicing and failing, frankly, a lot, and then learning a ton. I'm like, okay, now I'm at a certain level now. And that's how you get better at it. I mean, if you don't try, if you don't even afraid to fail, it's not going to happen.
Absolutely. And what you realize that the same skills to do manipulation is how you transfer someone. Starting how you stand and how you position your body to move people. We're in the moving people profession, and teaching those fundamental skills where you're really good at body movement and you can shift weight and literally closing your eyes. We do a lot of dance maneuvers in class, have people close their eyes and visualize moving through space. And I think, that's what we're trying to impart with our patients. So we need to have that same mind-body connection. And, again, that starts from day one. And then whatever skill you add to it, manipulation, P&F pattern, stand, pivot, transfer, you should not look dramatically different. You should have the same shifting of your body, the same way you move. And, great therapists are effortless. They're able to glide patients, even large patients, small. They just know how to get that done because they've done it. And they've done it more than once. They've practiced and failed, and through successive approximations have gotten better and better. And nobody's perfect. I learn every day, and that's why it's called clinical practice.
Absolutely. Learning every single day. I'm totally with you, Tim. Tim, thanks so much for all that you've done and what you've talked about today, because I definitely learned a few new things that I'm definitely going to keep in mind and try to implement. And, for our listeners who kind of want to know, where can people find you online and on social media?
On Twitter, I'm Timothy W. Flynn, I think. Again, I tweet out, and as Jeff Moore would say, Tim, you don't engage on there so much. And I do use it as a platform to put information out and get information in. But you can find me there on Twitter. Really, the Pain Reframed podcast, each week we're on that. We try to provide high-value content to folks that are both patients and clinicians of all types that are working with persistent pain. And so definitely check that out if you don't mind, Pain Reframed. And if you don't like it, most importantly, please give me a shout out on Twitter or on the EIM blog or wherever. Send me a note and say this sucks and tell me how we can make it better. Won't be offended. Having said that, I do think that there has been a distinct, I don't think the data is very clear, or dissolving of appropriate professional etiquette. And, being a researcher and an editor, I really think that, when people put things out there for peer review, for critical look, that part of being a professional is that of providing feedback that is critical but not personal. It gives the key elements that if this was changed, this would improve that. And where, again, I'm emotional, passionate. You guys probably know me if you've ever seen me speak. Yet I try always to be professional and empowering to others. So just like it kind of brings us back to where we started as a mentor and mentee, we can give critical, actionable feedback, but we're physical therapists. We believe in people, and it should be done from a place of helping, rehabilitating, and making this world a better place.
Man, what an excellent way to close it out, Tim. I love it. Thank you again so much for coming on, man. It's always a pleasure, and best of luck with everything with Pain Reframed. You guys keep killing it.
All right. Thank you guys so much, and you guys are doing excellent work, and it's a great topic, and just keep up the good work and keep putting yourselves out there. I really appreciate it.
No, the pleasure's all ours. Thank you. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.